Thank you for having me here today. I'm here to talk a little bit about the basics of endovascular procedures for dialysis access. I'm actually an interventional nephrologist here in practice in the United States in Daytona Beach, Florida. I'm practicing here in my hometown where I was born and raised, and I trained at University of Miami and then over to Emory University where I completed my fellowship training in nephrology and then further subspecialty training in interventional nephrology. We've been in practice here in Daytona Beach for about 13 years, where my practice exclusively deals with management of dialysis access for patients in our area and the surrounding communities that refer to us. We're here in a seaside town. I encourage you all of you to come visit here one day. We're a tourist destination here in Florida, where the weather is generally nice and right on the ocean. We're far away from you here in Egypt today. It is a dream one day for me to come visit you in Egypt, perhaps one day in the future. But I'm about 10,000 kilometers away giving this talk through a video presentation for you here today. And so one of the famous things of Daytona Beach is auto racing. What's unique about this town is that we have hard-packed beaches on the sand, and they actually used to race here in Daytona Beach on the sand. As racing grew more and more popular, they built the famous Daytona 500 Speedway track, where we have the Daytona 500 race every year and the Rolex 24-hour endurance races as well. So the basics of dialysis, as we all know, we're trying to clear the toxins and fluid from the patients and then balance the electrolytes. However, all of our hard works really go to no success at all without a functioning vascular access. And a good vascular access is really essential for the dialysis patients, and it allows our patients to live. Without good vascular access, you can't have good dialysis, and you can't really live otherwise. So in the United States, the goal has been to put fistulas in patients as much as we possibly can, and there has been a trend to put grafts in patients with very poor veins, but we really try to avoid catheters as much as possible. Fistula is essentially a connection between the artery and the vein, allowing for a conduit for dialysis to be used. It's really considered as the best overall vascular access, with lower chances of infection than catheters or grafts and superior blood flows. The downsides are somewhat cosmetic, where patients don't sometimes like the appearance of them, and there is some issues with maturation, which we can really help a lot with our endovascular procedures today. There's several different types of fistulas. The first type that we try to use in patients is at the wrist, called a radiocephalic fistula, which is a connection between the radial artery and the cephalic vein, where the vein is eventually cannulated. And here you can see in the pictures where the anatomy is and what a fistula looks like once it's developed and being used. The next more common type is the brachiocephalic fistula, which is a connection between the brachial artery and the cephalic vein. And the cephalic vein dives into the cephalic arch going in the thorax. Of note, that cephalic arch is an area that we sometimes have issues with, and we'll speak about some of the interventions that we use here. But in the inset picture, you can see a cephalic vein fistula being used. In our local practice, this is where we see the most fistulas being created in this configuration, because many times the forearm veins are somewhat small for patients to develop a working fistula. The basilic vein is also used, and that's generally a two-stage surgery, where the first stage connects the basilic vein and the brachial artery together. And the second stage, because it's a naturally deep vein, they require a second surgery to lift the vein up closer to the surface. When that vein is lifted up, you sometimes develop stenosis, which we call the proximal swing side of the fistula. And again, we'll talk a little bit about those interventions later on. AV grafts are also used in our patients. And we generally use grafts for older patients or patients with very poor veins, very small veins, that don't have adequate veins for fistula creation. A graft is basically, readily implanted and has a predictable performance and can be used relatively quickly. However, the downside of the graft is an increased risk of thrombosis and stenosis, and also risk of infection because it is a synthetic material that goes in the body. However, I need to reiterate that a graft is a superior option to a catheter most of the time because it allows for the patients to have a lower risk of infection than the catheters. AV grafts can be made in a variety of different configurations, down at the forearm, up at the upper arm, and when patients have used up upper arm access options, the thighs and chest can be used as well. Generally, we use a polytetrafluoroethylene material, which is a plastic-like foam material known as PTFE. However, grafts are also sometimes made with a bovine graft, which is used a bovine or cow carotid artery. The upper arm grafts are generally a brachial artery to axillary vein graft. Here you can see where the graft is sutured into the draining axillary vein. And the configuration usually has a cannulation within the mid-upper arm of the bicep. And again, here's another image of what a graft looks like when it's in function on the patient. You can see where the needle sites are with cannulation. Dialysis catheters are used in instances when a patient is newly presented to dialysis and a functioning access has not been created. In the United States, we really try to minimize our use of catheters because we know there's a higher risk of infections with these catheters over time. The advantages of catheters is that they're very easy to use and they can be used immediately. Remove them when needed. However, again, the biggest problem with this is the infection rates, and also we don't always get the adequate blood flows that we sometimes get achieved with fistulas and grafts. Catheters come in a variety of different types. Generally, in the United States, we use non-tunneled, non-cuffed catheters in a short-term setting in the ICUs or in the medical floors. However, when patients are discharged, we generally use a cuffed or tunneled dialysis catheter with a subcutaneous tunnel that helps to minimize some of the infection risk. In preference, we like to use the right internal jugular vein for catheters as the anatomy is more favorable and it's a straight line down to the right atrium where we get our best flows. However, when the right side is not available, we'll go to the external jugular veins or the femoral veins on the right side or the left side as well. Very rarely, when you have patients who have exhausted catheter options, we'll use a hepatic vein or translumbar veins. However, these are exceedingly rare in the United States. We generally try to avoid subclavian veins for any of our dialysis catheters because those subclavian veins can develop stenosis after a catheter is placed, which can interfere with any future fistula or grafts being placed in those arms. And here's what our general tunneled catheter looks like. We have a tunneled cuff here, which is placed under the subcutaneous skin and acts as a barrier to help minimize infection at the catheter. And again, here's an image of a diagram of what a tunneled catheter looks like. Sometimes they're confused for subclavian catheters. However, in general, we generally have the insertion of the catheter at the internal jugular vein and have a subcutaneous tunnel with the cup coming out from the chest wall. And we have the catheter here. This is what it looks like on the x-ray. We generally like to place the tip of the catheter at the right atrium for the best blood flows. And this is all a subcutaneous tunnel here that allows for catheter use. Again, our biggest concern of catheters is infection because the catheter acts as a conduit for bacteria traveling from outside of the body to inside of the body. And we can have sepsis, endocarditis, spinal emboli and paralysis, and cerebral emboli and strokes have even been noted. Some have even called our catheters a white tube of death. And although they are useful in short-term settings, we really try to minimize the long-term use of catheters in our population. Catheters are not perfect, and they can sometimes get dysfunction or poor flow. We sometimes see the development of fibrin sheath, which is tissue that grows around the tips of the catheter. This tissue kind of prevents the blood flow from going through the tubes, and we generally exchange these catheters. When we perform exchanges, we generally inject a small amount of contrast as we remove the catheter. And you can see here this long stringy area, that's actually the development of a fibrin sheath, which has encapsulated the catheter and prevented blood flow to come through there. The treatment for that is we use a balloon angioplasty and we slide through that sheath to break it up and disrupt the sheath. And you can see a repeat image that we've got a nice filling superior vena cava and right atrium, and that sheath has been disrupted. At that point, we can place a new catheter and get better longevity of the catheter than exchanging it without the disruption of that sheath. So in our instance, in our practice, we always look for a sheath when we're exchanging a dialysis catheter to give us a better longevity of the catheter after exchange. So interventions in dialysis access. There are a variety of different things that can be done. So what is interventional nephrology? And I work as an interventional nephrologist here. We work with our nephrologists, with our surgeons, with our primary care physicians, and our dialysis nurses and staff to provide focused care for the dialysis access. We do this through doing vessel mapping and planning for fistula graft creation, fistula maturation procedures where we sometimes have fistulas and grafts that are not maturing well, and we can perform angioplasty to help develop them. We also perform coiling procedures, which we'll speak a little about angioplasty and stenting. Also banding procedures for high flow fistulas and Steele syndrome, which we'll speak a little bit about, and thrombectomies as well. Kind of new to dialysis access for interventional nephrologists is the placement of endovascular AVFs, and we'll show you a little bit about that as well. Surgical fistulas are being done by a select number of nephrologists in the United States. However, in general, most of the time in the United States, surgeons and vascular surgeons are placing the surgical fistulas. Interventional nephrologists generally do the endovascular management of this as well. However, there are certain parts of the country where interventional nephrologists are creating surgical fistulas and grafts and having excellent outcomes. And of course, we also manage all the tunneled catheter and non-tunneled catheter replacements, exchanges, and removals as well. So this is our outpatient center. Again, we've been in practice for about 13 years, and our concept is to take care of the dialysis patients without going to the hospital. Here we have outpatient dialysis centers, and if a patient is on the machine and having dysfunction, we generally try to bring them to our dialysis outpatient center within a day or the next day to manage that problem. Because when a patient has a problem with their vascular access, they need that problem fixed, and then they need dialysis as soon as possible. So we've done this in a way to minimize some of the hospitalizations for our dialysis patients in the United States. This is kind of our lobby area, and we have a pre-op and post-op area here. We almost function as a mini hospital here. And I have 2 procedure rooms where we use fluoroscopy. We have 2 C-arms there where we do cases back to back. And I may average 8 to 12 cases a day on average in my center. The basics of interventions, we gain access to the fistula, usually directly through the fistula or the graft, using a micropuncture needle, which is a 21 gauge needle, and then we upsize to a sheath here. And everything is done with balloons and wires under fluoroscopy. These procedures are extremely safe when done. However, we have all the backup procedures and tools for any complications if necessary. And here I am performing my case. I have a scrub tech that scrubs the cases with me. We also have a nurse who's monitoring the patient's vital signs as we are doing procedures. And we have another radiology technician who operates the C-arms while we perform our procedures. So balloon angioplasty. Balloon angioplasty is kind of our baseline treatment for dialysis access. And the method is basically using a balloon under a wire and fluoroscopy to open up a stenosis. Now, as we all know, this can be generally a relatively traumatic thing. However, in a controlled setting with appropriate sized balloons, it can be very safely done. And in any cases of complications, stents and stent grafts are available to treat this. However, the mainstay of dialysis access is balloon angioplasty. We often see recurrent lesions and recurrent stenosis in dialysis fistulas and grafts, and some studies have shown that primary angioplasty success rates to be approximately 50% at 6 months. So we know that when we perform interventions on these patients, they many times require repeat interventions in the future, and that's one of the reasons we use our balloon angioplasty in our outpatient setting to help minimize our hospitalizations for these patients who need this kind of treatment. So what is the basics of angioplasty? Well, here we have a high-grade stenosis at a dialysis access graft. And at the graft in the vein, we have a tight stenosis here. That stenosis leads to disruption of blood flow. And ultimately, if that stenosis becomes too tight, the blood flow cannot pass through there anymore, and you develop thrombosis of the fistula of the graft. So in the management of angioplasty, we can pass a wire through that stenosis under fluoroscopy, and we use balloons. We generally use high-pressure balloons in dialysis access, much higher pressures than what's used in coronaries or other arterial systems. However, that's what's necessary to open up these lesions in dialysis access. We achieve angioplasty with full effacement, and you can see the post image here that we have a nice smooth blood flow here. This is going to prevent thrombosis. It's going to keep the access working better and give the patient a more efficient quality of their dialysis. One of the other things that we sometimes see with fistulas and grafts is thrombosis. And thrombosis generally occurs when there's a very tight stenosis that's limited the movement of the blood flow, and the blood flow stops moving and you develop thrombus. Thrombosis can also occur when patients develop significant hypotension. But for patients on dialysis who develop thrombosis, it's an emergency for the patient because number one, they need that access opened up and taken care of, and number two, they need dialysis as soon as possible. And so we generally try to get to thrombosed patients as soon as we possibly can because we need to be able to get that opened in a timely fashion for the patient to get good dialysis. In a thrombectomy procedure, we generally access the graft or fistula in a similar fashion as we would for an angioplasty. And we try to identify the areas of stenosis here. You can see here in these images, this kind of patchy area of contrast shows where the thrombus is. And we've performed an angioplasty here. Here we have a high-grade stenosis at that venous anastomosis of the graft. So we try to angioplasty that open. We macerate and open up the thrombus with the balloon angioplasty. And then we use a special balloon to drag out some of the thrombus and reestablish flow for the patient. And here the patient had an angioplasty with thrombectomy here, and we reestablished flow through the access. Now this can occur again and again in patients, and it is something that we're vigilant about, that we try to manage and get to in a timely manner for patients. Fistula maturation is also an important part of our management of our patients. And when fistulas are created, they are not always mature, and sometimes we need to perform angioplasty to help develop the fistula. There's a rule of sixes that has been used here that we use to develop when a fistula is mature. And generally 6 weeks after fistula placement, we use ultrasound to assess the blood flows and the sizes of the fistula. We generally want a blood flow of at least 600 milliliters a minute measured from the feeding artery, and a maximum of no more than 6 millimeters deep and at least 6 millimeters in diameter. If it's deeper than 6 millimeters, then it's difficult to cannulate, and if it's smaller than 6 millimeters in diameter, it's difficult to cannulate. So when we identify these kind of problems, we generally perform interventions to try to assist and help with fistula maturation. Here we have an immature fistula here, and it's actually a fistula that connects from the brachial artery to the cephalic vein. The images are a bit difficult to understand. However, if you follow the highlighted areas here, the brachial artery is at the bottom, and we have this connection to the cephalic vein here. The fistula has limited development here because we have some tight stenosis near the anastomosis and juxta-anastomotic segments, and we also have development of these branch veins here, which are accessory veins. These veins tend to take away flow from the main fistula and limit the maturation of the fistula. In this case, we were able to intervene on the patient. We performed an angioplasty here where we were able to angioplasty through those areas of stenosis, and we placed coils in at those branch veins there. These are endovascular coils which were used to block off the branches and promote greater blood flow through the main direction of the fistula and help promote maturation of the fistula here. Again, an outpatient easy procedure that we were able to do here. And here's what one of the coils looks like. This coil sits there permanently in that collateral vein, and this promotes an occlusion and thrombosis of that collateral vein. And by blocking the vein through this area, it promotes more flow through the draining cephalic vein and assists with fistula maturation. And here's our goal here. We have a patient here where we've marked the arm, we've successfully used this fistula, and we've taken out the patient's dialysis catheter with successful dialysis used after 1 week. The patient's very happy, has a much lower risk of infection, can take regular showers and swim. We have significantly reduced his risk of infection by removing his catheter and getting a fistula that's working well for dialysis. In our setting here, we also mark the fistulas for the nurses to cannulate here. And here we've got drawings directly on the patient's arm showing where the accessory veins are, where the artery is, and where the vein is, and where the best places to cannulate these fistulas are. Stent placement is also another procedure that we perform, and generally stents are placed when angioplasty has poor patency results or recoil, or in cases of rupture when balloon angioplasty complication has occurred and you need to seal open that vessel, a stent or stent graft can be used to take care of that. Another area of concern is that the brachiocephalic fistula and what we call the cephalic arch. And there's an area of the cephalic vein where it dives into the deltopectoral groove. This is kind of a junction between the muscles leading to the clavicle where we oftentimes get tight stenosis of the cephalic vein. And here's kind of the anatomy there, and you can see here where the vein passes through the layers of the muscle going into the thorax. This is an area that we sometimes get some compression of the vein and stenosis development. In this video here, I'll walk you through how we basically place a stent graft for a patient. This is a patient with a brachiocephalic fistula and has had recurrent stenosis of the cephalic vein. The first step is an angiogram, which we've performed here, and we've identified an area of stenosis right here at that cephalic arch. Again, this is an area of recurrent stenosis for the patient. Our first line treatment is we advance a catheter to the site, and we use our catheter here to manipulate our wire and give us a little bit of a better angle for intervention here. So this is all done under fluoroscopy, and we have a variety of imaging catheters and guide wires. This imaging guide catheter has a little hook to it, which allows us to advance the wire in the direction that we need to. So we place a wire there going from the cephalic vein down to the axillary vein. We did an injection of contrast, and this really helps us to isolate where that area of stenosis is. And we can see here at that cephalic arch, this is kind of where we see the junction, just leading into where the rib cage and thorax is. We've identified the stenosis here. The first line treatment for that is an angioplasty, and in this case, an 8 millimeter angioplasty balloon is used. This is an 8 millimeter diameter balloon, and we use that to fully efface and fully open up that area of stenosis. Post-angioplasty, we injected contrast here again. We did see some improvement of flow. However, there was some recoil at this site, and this is again an area that we've had recurrent stenosis for the patient, which has been completely problematic for the patient. We wanted to give a more durable treatment here, and in this case, we used a stent graft here. Here we placed a stent graft over the wire and through our sheath and advanced it through the areas of stenosis. Again, conscious sedation is usually used for this. Versed and fentanyl, we don't generally use general anesthesia for these cases. Here we've identified where the stenosis is, and we've lined up our stent graft at the area of stenosis between at the cephalic arch leading into the subclavian vein. And we can see here, I'm just lining this up under fluoroscopy. We want to be very precise in our localization of the stent graft. The next step is that we're going to deploy the stent graft under fluoroscopy here. And here we basically step back a few steps. This device uses a screw that we unscrew, and we pull a string, which acts as a ripcord that opens up the stent graft there. Now here we've opened up the stent graft at that cephalic arch, and we're able to go in with an angioplasty balloon, and we use the balloon to open up that stent graft. The stent graft basically acts as a tube that will help keep that area open and give us some better patency that will last longer than the initial angioplasty would. A repeat image here shows improvement of the flow and successful placement of the stent graft afterwards. So in this case, we're able to place a stent here. This is a procedure that can take, in our hands, maybe 20 to 30 minutes. The patient is given conscious sedation. Generally, we just use one Band-Aid, sometimes one little stitch, and the patient can go for dialysis immediately after this. And this gives us kind of a better result here than we would with angioplasty alone. At the end of the day, those are new, and we have some compelling evidence. So what are the new technologies that we're looking at with interventional nephrology? Well, drug-coated balloons are being studied. There's not a lot of data out there yet. However, there is some compelling evidence that balloons covered with paclitaxel and sirolimus may have better efficacy than just balloon angioplasty alone. Percutaneous fistulas are new, and we're performing more and more of these procedures. There's two main technologies available: the wavelength procedure, which utilizes a catheter placed in the artery in the vein, and a magnet that brings the two vessels together, which uses energy to connect the vein and artery and create a percutaneous fistula without surgery. And the ellipsis fistula, which is primarily performed under ultrasound guidance for creation, where we place a wire in the cephalic vein and pass that wire into the feeding proximal radial artery and use the device to fuse the two together and create a fistula. These are percutaneous creations of fistulas. You have to have the suitable anatomy for it, but it is a procedure that we are doing more and more in our practice as well. So the keys to success in access care are really working together. It's a collaboration between nurses, nephrologists, and the interventionalists or surgeons in the dialysis units and hospitals. At the end of the day, we're here to serve the patients in the dialysis units to help make these accesses work better and better. Timely care is important for us. We really want to get to these accesses and manage any problems so the patients can get good, safe dialysis without missing treatments. We really want to minimize catheter use in the United States as much as we can because of the infection risk. And it's constant communication, working with nurses, working with technicians who are working with our patients and the surgeons. And we really like to follow up with our patients, do surveillance and ultrasound on the fistulas, and remove catheters when we can. And at the end of the day, we really want happy patients and happy staff. And that's really the goal of our care as interventional nephrologists, to help facilitate everything. And this means happier nephrologists at the end of the day as well. So this is, again, our center. I invite you all, if you find yourself in the United States and you'd like to watch and learn a little bit about dialysis access, we'd be happy to show you what we do here. And here we are in Daytona Beach again. And I thank you for your time. And please let me know if you have any questions at all. Thank you so much.